I think we have time for a few questions. There's mics out there, I assume. Any questions for the panelists? I see one in the middle.
Hi, my name is Kapil Dandekar from Drexel University. Enjoyed the panel, and a question that I had is, by looking through some of the structures that you had in place for industrial and government-based healthcare systems, you were mentioning partners, but it was not completely clear to me from a university perspective to what extent these partners could extend to university researchers who are developing technology for integration into these smart healthcare delivery systems. And I'm wondering if you could comment specifically on that, and if there are any barriers to entry for people who are developing new technology to integrate into these systems, if there are if there are any issues that you see with this, or is that something that's built into your systems? Thank you.
Go ahead.
So what I did mention is that almost every technical product that we produce as a VERC it originates with our academic partners. And so we do a lot of translation and adaptation of those products into the VA. So there are no barriers other than really knowledge of the work that's being done. So I always accept business cards. I always listen to ideas and suggestions on what's going on. And then if there's a good fit, then we just work to build the partnerships. We have quite a bit of flexibility. It's very unique to a government agency because of the way the VERCs are set up. We have quite a bit of flexibility in partnerships with academic institutions. So again, always willing to listen to great ideas and figure out where there's a fit.
Yeah, thanks for the question, which gives me the opportunity to make some advertisement, I guess, as well. So we have multiple collaborations. I didn't go into too much detail because I wanted to share basically what we're working on and what our intent is to develop new solutions for healthcare systems in the area of smart services. But partnerships with academia play a role across. So from the point of view of developing new technologies that can be applied, particularly outside of the hospital, but also inside of the hospital. So smart healthcare delivery also is, for instance, to do surgery faster and use image-guided interventional tools to really interact with the interventionist, providing cardiovascular or oncological or neurological interventions, which of course requires very close collaboration between us and academic partners, clinical research partners, academic hospitals, but also technological institutes. From the point of view of healthcare delivery outside of the hospital, obviously I would say small and simple devices that can be used, yet of very high quality. I appreciated the comments about introduction of technologies and solutions in clinical practice, but we're dealing with people, and we need to develop solutions that are really robust and tested in clinical practice, which requires collaboration with clinical researchers, with academic hospitals, again, with healthcare providers, as the example I gave in Banner Health. But now with the next step we're taking with the digital platform, the HealthSuite digital platform, also taking it one step further to really develop solutions together. And also there, a lot of collaboration with academic partners in technology to some extent, but particularly also in the areas of industrial design, behavioral science. How do you develop a solution that really is used by an individual? How to reach out to the individual, to motivate the individual, and there's a lot. So it's not only technology, but very much also implementation. And the platform I showed, the HealthSuite digital platform, we have launched quite recently. First application that we have put on the platform together, actually with a university in the Netherlands. I'm based in the Netherlands, but we also have significant presence in the United States, so that can be done here as well. Is an application for COPD, where we have actually put a solution developed in one of our academic medical centers onto the platform, and we are co-creating the solution in clinical practice. And that actually is a tripartite partnership between academic research, the care provider outside of the hospital as well, and Philips as the industrial partner. So it's really a partnership between academic research, clinical implementation, and us as the industrial research and industrial implementation partner. And I'm very happy to discuss with all of you, well, not all at the same time, but individually some opportunities that you may see.
Thanks, Hans. Tetsu, did you have a thought?
Yep. So for us and industry, collaboration with academia is necessary because it is hard work to applying and implementing the service and solution. So because of that, it is difficult for us to at least in Fujitsu, it is difficult to conduct basic research. So I would like to rely on academia for this part.
And I'll just add that many of the universities I visit around the world have hospitals, associated medical research centers with the university. So there's a lot of interaction. You know, Stanford's an example out near where I am. Next question.
My name is Justin Shi from Temple University. I have a question about the VA system. I know of a system called the VISTA. It's being used in military veteran services a lot, and it's still being used.
Yes. Yeah, that is our the basis for our historical electronic medical record. We are currently in development for what's known internally as VISTA Evolution, which is the next generation of the electronic medical record for the VA.
And they have a question about the industry and academia and the government collaboration. You mentioned that the failure of an electronic health record system effort. And do you think that's the failure is because of technology failure, it's a policy failure, or it's a procurement management
first of all, I
failure?
want to say I wasn't speaking specifically about the failure of the electronic medical record in the VA. I believe our electronic medical record is 20 years old. It was the first electronic medical record. It was really significant. It significantly contributed to our ability to integrate healthcare across our continuum. What I was referring to is healthcare electronic medical record implementations that I have personally witnessed that have been disastrous. They've been billions of dollars. They've been disastrous. They have not improved. They've not been integrated into workflow. And so they've resulted in a burden on the providers, a burden on the staff that was not anticipated prior to the implementation. And personally, I believe that we've just underestimated it's either, you know, if you're going to be optimistic about it, we've, as an industry, underestimated the complexity of the social systems in healthcare. We've not designed in consideration of those. If you want to be a little bit pessimistic about it, you know, there's a big medical industrial complex, and a lot of people are making a lot of money. So it's probably a little bit of both of those things that's going on, unfortunately.
Yeah, I know of the VISTA database created by a Cambridge doctor, and it's still being used.
Yeah,
There's
no,
so
it's
many databases
yeah.
out there,
So
and
VISTA has been really robust. I mean, if you the issue we've had with VISTA in our electronic medical record is we've allowed unlimited customization. So we have 156 hospitals and 156 different versions of how VISTA is used, literally. So any kind of development of a clinical decision support tool has to be adapted 156 times, right? So, you know, anyway, we have a really robust electronic medical record. We have, unfortunately, not optimized its utilization, in my opinion.
Thank you.
It's something that even from the previous session I wanted to mention regarding the role of incumbents versus existing, new blood. So this is why when you said, you know, there's a lot of business out there that, you know, when you say I want to do something electronic, everybody wants to make a buck out of it. And that's their business. Same thing with healthcare.com. I mean, if Amazon can develop software with, you know, 1/10 of the people with 1/100th of the cost, and it's much more reliable than a new system, one has to question sort of whether these are the best people to develop it. So the question sort of at the meta level is, we are talking about changing universities, but we have universities trying to change themselves. And we're talking about changing industry, and industry is the coming to. Usually in business, if you want to have something disruptive, you don't go to the people who own the business to disrupt it. It just will not work. The music industry did not disrupt itself. It was somebody else coming from outside. So one of the questions that's bugging me is, if we really want to make transformation, who are the right people to come to the table? It may not be necessarily the people who are actually doing things now, perhaps in a different way. I just want to hear your comment. What do you think of that?
Panelists, thoughts on who's the disruptor?
Do you want to I think that is a great question.
I mean, think about university. We're talking
Yeah.
about how expensive it is.
Right.
My university can always provide with tuition. They're asking me to cut its tuition.
Right. I think you have to think about what drives disruption in industry, and that's the customer, right? The customer aligns, decides, chooses to get the service or the technology, to accept new service or technology that wasn't part of the picture before, right? So unfortunately, and this is my opinion, and with the very 2 minutes of thinking about this, we don't have an engaged a customer base in healthcare. We just don't. They don't feel ownership for it. If there was a disruptive technology, how do we get them engaged so that they own it? Right now, the system, the healthcare system, is intentionally designed to benefit a small subset of stakeholders. And they have a stronghold, right? Medical device, farm, big farm, physicians, right? So whatever is disruptive will have to be driven by the customer, and that means, in my opinion, an engaged customer base that's informed and they understand the deficiencies. They don't understand the deficiencies currently in the healthcare system. I think they intellectually may know about them, but they don't understand how significant the issues are.
I think you're absolutely right. And the example I gave with music was the
Yes.
music. It's actually people buy the music. Right?
Yes, exactly. So how do we create that incredibly engaged and informed customer base that demands something different, which is honestly what's happened with the VA, right? I mean, we're a fishbowl for the healthcare system. We really are. Everything that I described is going on everywhere else. So, but we, for better or for worse, have gotten the demand from our customer that what we're doing is not acceptable, and that has actually accelerated and facilitated transformation for us. So I think it's a very interesting study to see how this all plays out for us. It may be indicative of what might happen next.
Yeah, I would like to give a few answers, actually. I think changing the healthcare system is, the transformation is complicated because there's so many actors. So just one actor, I don't think will very easily change the whole system, and that's why we need to collaborate, and we have to collaborate with people that also are motivated to change. And there's, the example of Banner Health is one of them. We also work with National Health Service in the UK, in the United Kingdom, or we work with partners in Africa, where of course there's less established structures, and where sometimes it's easier than to change a system and implement a system together with stakeholders. And that is the complex world of healthcare, where at the same time you're dealing, of course, with people, generally also with fragile people that are ill or are suffering from conditions, so that you don't want to take any risk by providing solutions that are not appropriate or that adds complexity or cost to the solution. And that, of course, requires also a careful introduction of new approaches. So, for instance, in UK you have NICE, which is basically government organized to really make sure that the new technologies that are implemented are appropriate and that are affordable also from a financial point of view. And actually in Philips we try to improve efficiency as well as quality of care, and basically delivering care in a more appropriate and cost-effective manner. And so I think that, just speaking for our company, we have transformed quite a bit. We started with light bulbs, then we created X-ray equipment. In the meantime, we create image-guided intervention systems, and recently also vital signs monitoring systems, and introduced that into the home care domain. And now recently we have really stepped up into the healthcare IT. So I don't think that established companies cannot change. Of course, I think the ones that sustain, so we are now in existence for almost 125 years, they need to change themselves, and that is, I would say, a characteristic for companies that really are there to create new innovations and breakthroughs and new applications that are meaningful to people in the world, and that is what we are about. At the same time, particularly now with the developments in healthcare IT and services, I think it's the time to collaborate with other people that want to change and want to introduce innovations and breakthroughs into the healthcare system to the benefit of us all. And there I think it's not either or. I think it's a combination of different players that all are motivated to make better healthcare.
Yeah, thank you, Hans. And I'd like to also thank Heather and Tetsuro. Let's thank our panelists.
Thank you, panel. A great discussion. So we really covered a lot of ground this morning in the area of university partnerships with companies and what it takes to move inventions and research results eventually, maybe through a 10 or 15, 20-year process, into an IBM company eventually. So what we have now is a few minutes before lunch to open the floor to more general questions that you might have. And then this afternoon, we shift over a little bit more to the academic side and less on the industry-academic partnership. And I know particularly that NSF is interested in bringing academic rigor into the process so that new fundamental research results, many of them human-centered research results that relate to smarter services, can be published in the refereed literature and add to our collective knowledge in this area. Now, before I invite these kinds of questions, and maybe Alex might want to think about her framing of what I just tried to say, is I just want to thank profusely the MIT team who has made this possible. And so I want to call them out. So in the back of the room for audiovisual, we have Rick Kaufman, wherever there his hands up. We also have audiovisual. We have Charles Chosino. Thank you, Charles. We have a videographer, Raymond Fabregas. There he is. And webcast is Kevin Tierney. Okay, so thank you, gentlemen, for all your IT and web-based services. Because of your great expertise, we don't know how many people are watching us live, but some people are watching us live streaming on the web. And of course, this will be put and stored asynchronously so that others can watch it at the more convenient times, including some of your own colleagues in your own universities and companies after today. Also, we have the MIT organizing team. And that is a cast of characters, too, who have really dedicated a lot of time and energy to this, including, more than 8-hour days, particularly in the last week or so. In no particular order, we have Abby Horn, who you might not have seen yet. Abby, are you here right now at the moment? I don't see her. Well, you're gonna hear her this evening at the reception, because she happens to be a professional harpist. So she will be playing harp music in the background to relax us all after a very stimulating day. Okay. We have Julian Mariever, We have Laura Dobson. We have Jacqueline Paris, who's been spent a lot of time on this. Ana Quadras, who I think is here in the audience somewhere, or she's outside now. My own assistant, Fran Marone. And last, but certainly not least, because heading the entire MIT team, and she's dedicated a lot of energy to this, is Nicolene Hengen. So Nicolene, are you here? In the back. Thank you very much. Now, if there's a microphone that's portable, Alex, are you willing to articulate something that I tried to put together for you to maybe stimulate a few more questions before lunch? Lunch will start in a few minutes. And lunch will be served out there. You can eat it at your table. And then I want to say that we have an extended lunch period. So after that, the 11 new award winners for these new NSF awards all have poster presentations at the, okay, if you look at the registration desk, there's a door and a large kind of room to the left of that between the registration desk and the elevators. And so please go and take a look at the presentations of the various very exciting, very innovative programs, research and development programs of these new 11 awardees. So that's the plan in the near term. Alex?
Yes. So I just wanted to explain to you the structure of the workshop so that it doesn't, to avoid confusion. So the first part of the workshop was planned as this discussion about industry, academia, and the translational space in which the PFI BIG program navigates. And we'll end with the poster session of our first cohort of 11 awardees. And of course, we believe that that will inspire the discussions of the afternoon because they are different but not disconnected, which is we really want to take advantage of the luxury of having all of you here. You were not invited, casually. You are here because exactly where you are. And so to start thinking and helping us whether there is a fundamental research agenda that is not covered currently by the programs that NSF has, that is in this space. And that's something that Grace touched somehow this morning, and tomorrow our boss will touch further. Of course, it's open to discussion whether we are trying to reinvent the wheel or not. And we hope that this is really a new agenda that touches exactly in this human-centered smart service system that, of course, requires much more than engineers at the table. And so that's basically what I wanted to say. And so after, I think it starts at 4 p.m., the discussions, but every single panel will have after lunch a panel talking about the future, because really NSF wants to enable that future and fund things that we cannot imagine today. And so that's the discussion that we want to have. Okay?
Thank you, Alex. If I could say one thing, too, that traditionally NSF's research programs have been more or less aligned with the academic silos that you see, mechanical engineering, civil engineering, electrical engineering, computer science. And the NSF group that supports this workshop and these awards and the awards coming in the future really are pushing forward away from the silos toward interdisciplinary and what they call transdisciplinary research. And so we're going to be developing those ideas over the coming, this afternoon and tomorrow. Okay, so with that as a framing and also the discussions you've heard this morning, are there any other questions or comments or contributions?
Hi, Al Serpa from UC Merced. So I have two questions that I would like everyone to hopefully participate. So the first issue was regarding something that Heather brought up, which is the issue of expanding access to trying to solve specific problems. And I just wanted to call that there are other communities that are working specifically on these issues, and they are being somehow successful as well. So we should probably, as a group, also take a look at those. And specifically talking about mobile health things, that people in my community in wireless sensor networks have been working for a while, not only publishing for a while, and they have been quite successful in the sense that they started with very little funding, but they tried to work integrated with in medical teams. And they have done a lot of work with actual medical trials, working in hospitals, to the point that right now, at the University of Memphis, one of my colleagues is leading a very large NIH-funded center, just focuses on that. So there are other communities and other funding agencies that are also working on that, and perhaps we should take a look and try to integrate the efforts. These are issues related to sensing, using mobile telephony, mobile things integrated into a hospital, new mechanisms to do diagnostics and things like that, that are definitely part of the loop and part of the task that we are working here as well. The other comment is something that Jim and Patrick at the very beginning mentioned, which is there are some issues, at least in our experience with Paul and working with another IT company as part of this program, work is that there has to be some more meat in the call itself with respect to what is expected in terms of a cooperative research agreement. And what I mean by that is that in general, people in academia are doing the heavy lifting of writing the proposals. They find a partner, but there is no really meta agreement at that stage at the time of submission of the proposal. Only when the proposal is funded, then we rush like crazy because we need to get this cooperative research agreement done. And in general, it just doesn't work. It doesn't work because only at that stage we involve the lawyers, and then we start the discussion, and then nothing happens, and then we're stuck. In my personal experience, by working with this, it was very, very hard to get the CRA done, to the point that at some point we just gave up and said, well, this is not happening. We are going to lose the grant because this is not going to happen. We had, only because we are very small, we're the new baby university in the UC system, we have to basically all the way to UC President Janet Napolitano say, please make it happen. Main counselor, an exception to the entire UC system, we got it done. But this is not the right way. So our business development person mentioned two things. You need to get technology transfer office from the university out of it, something that Patrick mentioned, because they are always trying to scavenge and trying to get the last back out of it. The other point also is that there has to be a meta agreement to get the lawyers out of the main negotiating conditions. So one of the ways to do this is in the call itself, you could have a template or something that says, at the time of submission, you need to have agreed upon the main issues in a relatively non-binding way, because there are legal issues here, but the main issues with respect to royalties, respect the issue to, how do we share intellectual property, design. So those conditions have to be already in place and signed by both parties. So it's nothing non-binding, it's not a full agreement, but the main negotiated conditions are there, such that if the application is successful and gets funded, then you're not renegotiating everything, you're just doing the fine-grained letter of something that has already been negotiated. And that would dramatically help, move the ball forward. Thanks.
Okay, thanks for your comments. I have to confess that I was one of the reviewers of this past round, and so I'm familiar with some of the frustrations that you might have with the written agreements for the proposal with larger companies. I think with the MIT's tradition, the mens in manus, minds in hand, we have perhaps the largest industrial liaison program of any U.S. university. Perhaps Stanford is equal, way over 200 companies that participate with our industrial liaison program. And we have lawyers here who are very, very familiar with working with large companies, medium and small companies, and dealing with IP issues. And so I have my own favorite one. I call her the can-do lawyer. So rather than lawyers putting up timeouts and say, let's get this, let's get that, let's milk this dry, she has a way of getting to the middle of something so that everyone is happy. So there's a culture here, I think, in the legal environment at MIT to get to yes rather than find answers for no. But I think this could be a major problem in many places. Any more questions? Here's one up here at the corner.
Yeah, this is just a comment based on that last comment. Thanks. I think the LinkedIn group, the discussion group on LinkedIn, If people have ideas about, the types of conversations that should happen and what a checklist should be, probably faster than having it loop into the system would be to get it out there into those discussion groups. And if you haven't used the LinkedIn discussion group, I urge you all to go there. There is some good material there. Sometimes you have to dig, but this sounds like a perfect thing to get a discussion going on.